Thank you. I'm very grateful to Dr. Mer and Dr. Sharma for their invitation. Probably has to do with your French connection, Roxana. It's an honor to be here, truly. These are my disclosures. Now, the topic of DAPT duration following stenting has generated a lot of data and a lot of confusion, and I'll try in 10 minutes to summarize where we are. This is a brief schematic display of the various randomized clinical trials that have compared various durations of DAPT after DES, and you can see that there's a flurry of trials comparing all sorts of durations, and they provide somehow conflicting results, so it's really unclear for clinicians what to draw of the literature. Let me start by looking at whether we can abbreviate DAPT duration compared to the conventional orthodox duration of 12 months following DES stenting. Well, there have been a number of trials that have looked at shorter duration compared to 12 months or longer after DAPT, after stenting. And many of these trials were open-label, non-inferiority trials, and I'll revisit this. And the message from these trials has been very consistent. Let us start with major bleeding. As would be intuitively obvious, longer DAPT duration is consistently associated with more bleeding. What was observed, though, is that longer DAPT duration was not associated with a clear reduction in the risk of myocardial infarction or with stent thrombosis or various composites of these outcomes. Now, another strategy that has been put forward more recently is to not abbreviate DAPT duration, but tone down the intensity of DAPT treatment by, for instance, reverting from potent antiplatelet agents such as ticagrelor, prasugrel to clopidogrel early after stenting or after ACS to try to minimize bleeding. This is the example of the TOPIC trial. It was recently published in the European Heart Journal showing that you can reduce bleeding and therefore reduce net clinical benefit that way. There doesn't seem to be any clear effect on ischemic outcomes, but this trial was very, very severely underpowered, and there's a clear reduction in bleeding. However, these trials generally have limitations on the methodologic standpoint, and these limitations are not overcome by pooling or meta-analyzing them. Many of these are non-inferiority DAPT duration trials, and if you look at non-inferiority trials, you have to look at the expected event rate in the reference arm, the actual event rate in the reference arm, and as you can see in many of these trials, it was much lower. And then you have to look at the non-inferiority margin, remembering that often the non-inferiority margin is based on a percentage from the expected event rate. And therefore, your non-inferiority margin that was low when you started off, actually, in reality, is much higher than what you anticipated, and sometimes is higher than the actual event rate in the reference arm, meaning that you have to accept as non-inferior a treatment that often results in a 100% or more increase in the ischemic event rates. Another problem we have is that in these open-label randomized DAPT duration trials, there are crossovers and loss to follow-up. And these crossovers and loss to follow-up are not evenly distributed between the two randomized treatment arms. They're biased towards one of the two arms. And if you look at the trials, and I'm going to be very clear that some of the trials I'm criticizing are trials I was associated with. And this has to do with the resources that are available for these trials. But when you look at the total number of crossovers, the numbers of loss to follow-up, you can see that they sometimes, not always, but they sometimes vastly exceed the total number of outcome events on which you base your interpretation of the trials. And I think that has to really mitigate our interpretation of some of the evidence we have for these trials. Now, the flip side of the argument is there is also data to support the idea that longer duration than 12 months is better. We've seen trials that support the idea that shorter duration creates less bleeding and no increased ischemic risk. There are trials that support the idea that longer duration than 12 months is better. For instance, the DAPT trial, a large, double-blind, randomized, extremely carefully conducted trial shows a clear reduction in stent thrombosis with prolonged thienopyridine treatment after a year, with a 70% reduction in stent thrombosis, 1% absolute terms, and a 30% reduction in MACE, 1.6% in absolute terms, with prolonged thienopyridine compared to placebo beyond a year, up to 30 months. Now, there's a price to pay for prolonged DAPT duration, as expected, increased bleeding. And there's a disappointment that there was no signal of reduced mortality. In fact, if anything, all-cause mortality is trending in the wrong direction with prolonged DAPT, and that must have to do with bleeding. Another important piece of evidence is the large Pegasus trial, which is not specifically looking at post-PCI DAPT duration, but at post-MI DAPT duration, prolonging ticagrelor more than 1 year after MI. But the overwhelming majority of these patients were PCI patients, and it turns out that this is associated with a reduction in CV deaths, MI, stroke, very consistent across the 3 components of the outcome, but also associated with increased bleeding. So you have to pay a price for the protection against ischemic events. So how do we make sense of these conflicting results? First, the clinical context may be important. Now again, we don't have consistent observations from the trial. In the DAPT trial, it didn't seem to make much of a difference whether you were an ACS or a non-ACS patient. There was a clear reduction in stent thrombosis and myocardial infarction, regardless of clinical presentation, with prolonged thienopyridine treatment. And there was a consistent increase in gusto, moderate, or severe bleeding, regardless of clinical presentation, with prolonged treatment. But in the other trials, if you look at a pooled network meta-analysis of the other trials, there seems to be a consistent message for prolonged DAPT duration in terms of major bleeding. You have increased bleeding with prolonged DAPT duration, regardless of whether you're stable or ACS. But in terms of efficacy, there doesn't seem to be any protection against ischemic endpoints in stable CAD patients, and there seems to be a borderline interaction with benefit in ACS patients. Certainly, if you pool all of the post-MI trial data and look at whether in post-MI patients, specifically post-MI patients, there's a benefit to prolonged DAPT duration, the answer is yes. This meta-analysis shows a reduction in MACE, a reduction in CV deaths, a reduction in MI and stroke and stent thrombosis at the expense of increased major bleeding. Now, if we have to make choices in clinical decisions, maybe risk assessment may guide clinical decision-making, very much the way CHADS and CHADS-VASc help us decide on anticoagulation in AFib patients. Maybe risk scores can guide DAPT duration. Well, the first attempt to do this was the DAPT score, available online and in an app as well, which is a score trying to predict net clinical benefit in patients in the DAPT trial based on patient variables and procedural variables, 9 variables altogether. It has a Gaussian distribution. The median value is 2. And if you dichotomize patients according to whether they're below or above median, what you find is that for patients with a DAPT score of less than 2, there's no clear benefit in the prevention of ischemic outcomes, and there's a clear increase in bleeding outcomes, whereas if you have a DAPT score of 2 or more, there's a massive benefit in the prevention of ischemic outcomes and no clear price to pay in terms of bleeding. So that would seem to ideally dichotomize patients. A limitation of the DAPT score, however, is that it needs to be prospectively validated in future randomized trials, not in observational studies looking at other interventions. Another method to risk stratify has been the precise DAPT score, which is trying to predict bleeding risk, focusing on bleeding risk using 5 simple predictors: age, prior hemorrhage, white blood cell count, hemoglobin, and creatinine clearance. It's a score of 0 to 100. And what happens is that if you look at patients with a very low or moderate bleeding risk, which means less than 25, you have no increase in bleeding in these patients and a clear benefit in preventing ischemia. And therefore, your net effect in yellow is beneficial up to a score of 25. Above 25, when you have a high bleeding risk, then the excess of bleeding offsets the benefit in ischemic outcome, and your net clinical benefit plummets. And you can see that it takes 65 patients to prevent 1 event if you have a precise DAPT score of less than 25. It takes 38 patients to get harm if you have a DAPT score of a precise DAPT score of more than 25. And if you now focus on the ACS subgroup, you can see that the numbers are even smaller, with more benefit and a lower number needed to treat and a lower number needed to harm as well. So it seems that excluding bleeding risk is really the way to go to make clinical decisions. This score has been published and also available online in this calculator. A very similar approach was used with the Paris risk score that Dr. Marin led, and this effort is looking at thrombotic risk and bleeding risk, and you find very much the same as in the precise DAPT analysis, which is if you have a low or intermediate bleeding risk, then you offset the harm from potential bleeding with clinical benefit in preventing ischemic events. But if you have a high bleeding risk, then you get net clinical harm because you no longer no longer get a benefit. Finally, maybe a way out of the conundrum would be to use long-term monotherapy. I will not, in the interest of time, dwell on the trials, but there are 2 large-scale randomized trials that are ongoing that are looking at long-term monotherapy with a potent agent such as ticagrelor, trying to get rid of the aspirin and therefore the attendant bleeding risk related to combining 2 antiplatelet agents. Global Leaders has completed enrollment. Twilight, led by Dr. Marin, is progressing quickly, and I think we'll have strong data to see whether this is the solution out of the conundrum. In the interim, how do we make clinical decisions? I'll try to summarize it in one slide. I think we should have 2 different conversations based on the clinical setting. The default proposal should be short duration for patients who are elective PCI, particularly if they have a prior bleeding or a high risk of bleeding, such as defined with the precise DAPT score of 25 or more. If the patient prefers discontinuation, obviously, or is poorly adherent or has planned surgical procedure. Conversely, we should consider by default a longer duration for all patients in a post-MI setting, particularly if they have high-risk features, for patients with a DAPT score of 2 or more, patients with anatomic factors such as left main or multivessel disease, and procedural factors that predispose to stent thrombosis, such as multiple, long, or small stents. Thank you very much.